Last talk will be by Dr. Dutson, evaluating tactile feedback in robotic surgery for potential clinical application using an animal model, and we are very much looking forward to that.
Thank you. I'd like to thank Dr. Scott and Bispo, and as well as the SAGES program committee for selecting this talk for SAGES. We're anxious to present some of the work we're doing at UCLA. Let's see if I can get this right. I am on the scientific advisory board for Titan Medical. I'm really hoping for a day when that's actually relevant, but for the moment it doesn't really mean much. And even though we started out this session at USC, we're at least ending at UCLA, so I'm very happy about that too. This was an NIH R21 project funded through NIBIB and NIH, and to speak about tactile feedback and robotics, it's sort of a hot button topic in the engineering world certainly, and to new users of robotics it becomes important. I wanted to start out with some definitions. First of all, we throw around the term haptic feedback, and to most people that's naturally understood as one of the 5 basic senses, the sense of touch, but really it needs to be broken down into the idea of tactile feedback and something called kinesthetic or force feedback. These are different. Tactile feedback is mediated by mechanoreceptors in the fingertips where they are at a predictable density and provide specific information to the brain. Whereas force feedback is actually mediated by something proprioreceptors, which provide proprioception. These are Golgi bodies, skeletal striated muscle, and things like this, so that your brain, mediated through your cerebellum, knows where your elbow is, knows where your wrist is, knows where your fingers are, and knows the amount of force that you're using to maintain that position in space. So this is what haptic feedback is conglomerated. Now, when you look at robotic systems, some of the criticisms that have been ongoing since the very first days were that this is very expensive, it's very big, and I can't feel what I'm doing. I used to think that I couldn't feel what I was doing when I started doing laparoscopy, but this robot proves that I really can't feel what I'm doing. The reason you can't feel what you're doing is because there are no systems that are sending that information. Now, in the very early days, people said, well, we've decided we don't need haptic feedback. It's not important. And history supports that, because if you look at the last 15 or 16 years of use of robotic surgery, operations are done safely without the sense of touch. The trouble is, you can't logically or scientifically answer the question as to whether or not haptic feedback is important in robotic surgery unless you actually have a functional system that you can test and answer the question in an appropriate way. Another interesting point about robotics that we tend to, I would say, ignore, but is more relevant, especially in the light of Dr. Birkmeyer's recent paper showing that what happens in the operating room is actually important when it comes to outcomes. If you look at the Da Vinci system itself, the graspers are actually able to generate forces which far, far exceed what tissue tolerances are, especially tissues in the gut. It's usually around 6 newtons or so that we start to see pretty significant damage and crushing forces applied to tissues. And the machine itself can generate 2 to 3 times that easily, but you need that. You need that to hold a needle and to do suturing and other things like that, to tighten knots, etc. Our group has previously designed a tactile feedback system which we integrated onto the Da Vinci robot, and our prior work has shown that if you have this system in place and you have subjects do FLS testing, you can actually demonstrate by measuring their grip forces, which we're able to measure with the system, they have a significant reduction in their grip forces while not affecting their performance of the tasks at all. In fact, what we noticed was a non-significant improvement in task performance, but we didn't tease out all the possible confounding figures for that. So the aim of this study, which was in evolution of our previous work, was to check the grasping forces with this system in vivo, because up to now we had only done it in a dry setting with box trainers. We also wanted to look at whether or not this question is relevant from a tissue damage standpoint. So we wanted to know what the incidence was of tissue damage in the shadow of what the actual forces generated at the graspers are. So we wanted to ask an intelligent, focused question: does it really make a difference clinically? So this is a sort of schematic of the device that we actually has been in evolution over the last 10 years or more. We started out with putting a FlexiForce off-the-shelf piezoresistive sensor within the grasper jaws. We have a peripheral interface controller which takes the information from that FlexiForce system and distributes it to pneumatic arrays, which actually can be housed in a very low-profile system within the console itself and provide pneumatic pressure directly to the surgeon's fingertips on the masters. We started out by improving this latest iteration to something that was waterproof, getting the seal on the grasper so what didn't short out when we put it into a wet environment. Took a couple of years at least. And what you see on the right-hand side is the FLS peg transfer task being performed underwater. And that was to verify that the signalings that we were getting from these sensors are still accurate. On the user's end, we calibrated each of these. If you look on the left upper picture, you'll see 6 pneumatic chambers. This is all soft and totally flexible. It's made out of a soft rubber-like material called PDMS, and there's a membrane over that, and 6 little balloons will blow up in a corresponding force to what's being exerted or sensed at the grasper tips. And you can see there how they fit into the masters. They're completely non-obstructive, and they actually give you an anchoring point for your finger when you're holding the masters, and most people felt this improved things. Based on previous physiologic studies, we optimized the system so not only the distribution of the actual pneumatic chambers, but the actual levels of force that were transmitted to the fingertips were at 5 discrete levels, either no force or levels 1 through 4, and they corresponded to those levels, 0 psi up to 40 psi. And we know from previous work that this is what people are able to discriminate between and differentiate between fairly easily. Now, in this study, we took 19 subjects, volunteers. We had IRB and ARC approval. 5 of those subjects were experts, meaning that they were attending physicians, attending surgeons who had done at least 6 robotic operations, and 14 subjects were what we called novices. These were surgical residents and or attendings who had had less than 6 cases of robotic experience. The reason we chose the number 6 is because I had done previous work in my fellowship showing that the adaptation to the console and the user interface was around 5 to 7 cases before that effect went away. And what we had these individuals do was run the bowel 10 times. And in the first scenario, they had no haptic feedback. In the second scenario, they repeated it and they had haptic feedback turned on. In the third scenario, repeated it again and haptic feedback was turned off. Now, what we had them do, and I'll show you a picture in just a second, was basically grab the bowel. This is in a live animal who had laparotomy. The bowel was exteriorized so that we could harvest it while the animal was alive and anesthetized and look at actual tissue damage. And I'll show you this picture right here. This is a picture of what we did. We looked at tissue damage scores. We measured the grasping forces with every grasp and correlated those back to the damage scores. We also gave survey questions at the end because if we designed the system that was accurate but people hated it so much that they would never ever use it or they didn't feel, even if they didn't feel it worked but it did, it still wouldn't be really usable or helpful. So the way we judged the tissue damage was we looked at histologic slides. Our pathology colleagues looked at the histologic slides of areas of damage, and they came up with a scoring system that they were then able to blindly validate amongst themselves and go back and assign a level 1 light damage, level 2 medium, or level 3 heavy damage. Now, on the left is an example of light damage, on the right is an example of more heavy damage, and basically heavy damage is, the light damage would be like what I call a hickey when I'm operating versus a true serosal tear in the heavy damage. Now, if you look at the results of these trials, we had 30 data points basically for each participant. There was a significant reduction in grasping forces for both the experts and the novices, highly significant. The tissue damage, as you would expect, was significantly decreased in all subjects because all subjects had a reduction in their grasping force. And there was also a significant correlation, again, as expected, between the grasping forces themselves and what we saw in terms of tissue damage. Additionally, decreased forces and tissue damage were actually retained through the third trial, and that becomes important because we believe it means that although the system provided immediate results in the second trial and it was retained through the third trial, that there is an innate as well as an adaptive learning process that goes on here. If you look individually at the grip forces, these are novices, you can see that the difference between the first trial, no haptic feedback, versus trial 2, second haptic feedback, there was a largely significant difference, but in trial 3, the numbers only drifted up slightly. Experts had also a significant reduction in their grasping forces as soon as the system was activated, and they retained it, but we did not see a correlating tissue damage reduction, which implies that experts know how to use the robot at whatever force level without injuring the tissue. Again, if you look at all subjects, which are a total of 19, there was a significant drop. If you look at the distribution of types of injuries, blue is level 1, yellow is level 2, red is level 3. There was still level 3 damage occurring in the second trial with haptic feedback, so that's something I think that it's important. When you look at the experts versus the novices, we did not see that same correlative tissue damage. We did see, however, a linear relationship between the damage and the forces exerted, as would be expected, and survey data basically said that these individuals, when they went through and used it, the ones who felt that they could feel what was going on and it did make a difference in what they were doing, correlated exactly with what their results were. So what does this all mean? I think what this means that decreased level of force and damage when tactile feedback is available and retained is important. This is important. Expert subjects, although they showed a decrease in the force after the second trial, they did not have the same correlative damage results. In the correlation between what people thought of the system and what their actual results were matched well. And I think the final bottom line of this is that even though we've been asking the question over and over again, I think it's pretty clear in this trial, as in all of our previous work, that the addition of tactile feedback to robotic surgery may in fact improve safety, especially in the surgeon's early experience on the system. And I think we've shown that again and again in dry trials, and now we've shown it actually in live tissue. So with that, I'd like to thank the committee and thank our moderators, and I'd be happy to entertain any questions.
Wow, that was amazing. Thank you very much for that, and we will take questions from the floor, and Dr. Bispo is going to finish out the session.
If you take, if you take a look in the past, you can remember the time that the cost problem was worse. So around the years, this difference would be supposed would be going lower, lower, lower. I believe that will not disappear, but the real impact of the cost will not be a very big, serious problem in the near future. Regarding the advantage that when you think about the bleeding and pain, et cetera, how do you believe, how can, in your opinion, how would be the impact of this kind of feedback, this kind of resource, to convince more surgeons that come to the robotic world? If you don't be worried with the costs, if you take a look in the advantage, and if we cancel this kind of disadvantage, how can it improve the number of surgeons in the hospital that can include in this kind of surgery?
Well, thank you for that question. It's a great question. I think that one of the resistances that surgeons have had to employing the robotic device, if cost concerns were equal, is that they can't feel anything at all. And we know that if you look at video, blind video of surgeons, and look at what you think you see is going on, it correlates very heavily with patient outcomes. So I think if you can make the statement by the introduction of this technology is going to soften the negative physiologic impact that you have on the patient when you're working on sensitive areas, and therefore is likely to have either a direct or indirect improvement in patient outcomes, I think that argument holds water. Thank you.
Yeah.
Thank you.
Very nice presentation. Two questions for you. First is that one of the ways that obviously surgeons are compensating by having no feedback is to choose clamps that have maximum grip strength. And so it's sort of like using a series of torque wrenches when we work so that we don't strip the screw. So have you tried your system with multiple different grip strength instruments And can you stay out of level 3 damage just by using the right instrument? Okay. Second question is, obviously what we also give up is really precision potentially when there is any feedback that pushes on either the instrument or our hands. Okay. And so have you tried to sew with your system or some precise movement to see whether you give up, how much you give up in terms of precision and loss of tremor do you get back by having the feedback that you get? Okay.
Thank you for that question. I'll answer the last question first. We have not used it to sew yet because we don't have the instruments that we would use to sew. We've been following a path of using the same instrument that we've modified to hold the sensor. But the idea is to get a baseline down so we can spread that to all instruments, because your point is exactly right, that the force distribution over a surface area is highly critical when you're talking about whatever it is that you're doing. The grasper that we use was a Cartier grasper, and we've modified it over time so it will hold the sensor. The sensor itself actually doesn't affect tissue handling in any way that any of us have been able to perceive, including the independent and blinded folks. I'm trying to remember the first part of your question. Right, so we haven't gone through the score of instruments because we haven't had the system available to put on all of the different instruments. This is our first live tissue trial.
My question is a two-part question. So the first question is, how did you calibrate the system for the force measurement? And then to follow up that, did you find a range of error in that force measurement?
The range of error is very narrow, actually. We've been taking force measurements for over a decade now, and we keep tweaking the system until it gets extremely sensitive and very accurate. There is an exact linear relationship between the forces that are distributed, and the hysteresis of the system was measured very early on with thousands of trials. So it is actually extremely accurate, even though it looks maybe a little low-tech on the user interface.
So is it somewhere around the range of like maybe plus or minus 5%, plus or minus 1% in terms of what the true force?
Yeah, it's 1%.
1%,
yeah.
Okay. And what was the sensor you said you used again?
So it's a FlexiForce piezoelectric sensor, just off the shelf. But we have an RO1 going on right now using a much more sophisticated sensing system that will also give us shear force information.
Okay, thank you.
Sure.
Dwight Yen with the Food and Drug Administration. Obviously, with this time limit, you weren't able to talk about your design. Could you comment on stability of your force feedback? Do you have any issue in the development of this force feedback?
You mean at the user interface itself?
Yeah.
We have not. In the very early iterations of this project, in the PDMS block and pneumatics, in the pressure generators that we use, the compressors, the error rate is extremely low. It's, as I just mentioned, it's less than 1%. It's very, very accurate.
Okay, thank you. And we don't have more time, unfortunately, so I'd like to thanks for everybody in name of Dr. Scott and myself, and finish the session. Thank you so much.